Welcome everyone to this special Association for Molecular Pathology webinar covering Medicare lab test payment, preparing for the upcoming PAMA reporting requirements. This presentation is supported by AMP's advocacy committees, the Economic Affairs Committee and the Professional Relations Committee. I'm Jay Patel. I chair the Economic Affairs Committee for AMP, and I'm a pathologist at the University of Utah and AREP Laboratories.
I'm Eric Kodak. I'm a molecular pathologist at the University of Washington in Seattle. I'm chair of AMP's Professional Relations Committee.
Thank you, Eric. Following the presentation, we'll be joined by Dr. Vicki Pratt and Clarissa Blattner for a Q&A session. Before we get started, a note here that AMP is providing this webinar for educational purposes only. If you need more specific guidance or assistance with compliance needs regarding PAMA, AMP encourages you to seek out licensed counsel and/or reach out to CMS. So why are we here? What is PAMA? PAMA is law. PAMA is comprehensive legislation that was signed in 2014, and it had an impact on Medicare physician payment. Section 216, more specifically, revised the Medicare payment system with the intent of the clinical diagnostic laboratory test, the mechanism through which clinical diagnostic laboratory tests are reimbursed, the CLFS, to more closely reflect private payer rates. Other impacts of PAMA included the creation of ADLTs, the creation of the PAMA Advisory Panel, and MAC consolidation, among others. Importantly, PAMA requires the collection and reporting of data from applicable laboratories, that's a key term under the law, applicable laboratories, on payments that the laboratory receives from commercial payers for every unbundled test. CMS then sets the CLFS rate for most CDLTs for the following 3-year period using the weighted median of these reported data. Now, we have seen, because we have been working under PAMA for a number of years, that there is an impact of the first reporting period, and it was significant. PAMA cut Medicare payments for laboratories. However, the first round of data collection was very flawed, and reduction in the payments was greater than CMS estimated, with the price cuts totaling $670 million versus a pre-PAMA estimate of $390 million. And one of the main reasons why we're here today as AMP is because molecular tests are particularly affected. So of the over 230 molecular tests on the CLFS in 2017, the majority received a decrease, while only 20% received an increase. What's next for PAMA? Well, because of this negative effect on laboratories, AMP and others have been advocating for reform for a number of years. We'll hear more about that from Eric later on in the presentation. But in the meantime, Congress has been kicking the can down the road on the pretty significant cuts to laboratories that would happen under the existing legislation. And that means that it has delayed reporting periods as well as payment cuts several times over the years. And the latest iteration of this was back in February of this year under the Consolidated Appropriations Act, which changed the requirements for CDLTs that are not ADLTs and instituted a payment cut delay for 1 year, as well as the reinstatement of the reporting period. All applicable labs must report this year. And it shifted the data collection period from 2019 to 2025. So certainly that's a positive development, given that we as laboratorians, want to have the collected data represent real world, real-time facts on the ground. So the current, for the upcoming PAMA reporting period, the data collection period is January 1st, 2025 to June 30th, 2025. And the data reporting period itself begins on May 1st, 2026 and ends on July 31st of 2026. So what is an applicable lab? Does your laboratory need to report under PAMA? So there are a number of ways to tell. And one is that if your laboratory bills Medicare Part B in one of these ways under its own NPI, or if a hospital outreach laboratory on Form 1450 under the bill type 14X. too. So if your laboratory meets the majority of majority of Medicare revenues threshold. So this means that when you add your revenue from the Medicare CLFS and the Medicare PFS, physician's fee schedule, it's more than 50% of your total Medicare revenue receipts. And importantly, your laboratory would be above the low expenditure threshold if you're expected to report. So this means that laboratories that receive less than $12,500 in CLFS revenues during a data collection period do not need to report. And importantly, Medicare Advantage plan payments are excluded for the purposes of determining whether the lab meets the low expenditure threshold. Some more information on determining, an applicable laboratory, because of course this is very important in terms of determining the obligations that your laboratory has for reporting. CMS, excuse me, has some wonderful resources on this, and we are directing you to those in the links provided. And in addition, CMS, excuse me, is sending letters by mail to entities that it believes through its resources are applicable laboratories. And in general, the changes that have been implemented result in more laboratories being expected and obligated to report. And this is due to, this is purposeful. So, the idea is that a broader sampling would be more representative of the actual data and would yield more informative and more real-time representative data for decision-making around reimbursement rates. The changes that have had an impact on the increased number of labs being expected to report include those listed here. And specifically, CMS excluded Medicare Advantage plan payments from the total Medicare revenues, and CMS changed the definition to capture labs that bill Medicare Part B under CMS 1450 under Bill Type 14X. So the net effect of both of those was that the number of labs meeting that majority of Medicare revenues threshold was increased. And bottom line is that there's an increase of 1,708 applicable labs, reporting for a total of 3,650. And this is going to mean that many labs that did not report in 2017 are now required to report. So what specifically needs to be reported? So applicable laboratories need to report the applicable information. And this means the specific CLFS HCPCS codes associated with the test. And the code list is provided at the link there in the slide. Importantly, do not include codes such as 81479, which is an unspecified code that many in the molecular professional sphere will be familiar with. Each private payer rate for which final payment has been made during that data collection period should be reported. In addition, the associated volume of tests performed corresponding to each private payer rate should be reported, along with, finally, the NPI number of the laboratory. So what is a private payer? Private payers have different stripes. So they can include traditional health insurance companies, group health plans, companies that are operating Medicare Advantage plans, or companies that are operating Medicaid managed care organization plans, MCOs. Is it a private payer payment rate that needs to be reported? So this is a question that could be asked as laboratories are going through the exercise of complying with the PAMA reporting requirement. Some important notes here are that final claims only should be reported. So it must be a claim that was paid during the data collection period. The date of service and the date of claim submission are not relevant for this purpose. Do not report payments of $0. So payments of $0 or denied payments should not be reported. Only report a payment if it's associated with a specific HCPCS code. No encounter level payments. So this means that if a private payer groups test level payments in an encounter payment instead of by individual codes, those rates would not be applicable for the purposes of reporting under PAMA. And finally, factor in discounts. So the private payer rates reported to CMS must reflect all discounts, rebates, coupons, or other price concessions made by the laboratory. I'm going to hand it over now to Dr. Connick.
Thanks, Dr. Patel. So how does a laboratory report? So there's a couple of different components here. So there's the CLFS module user registration. You have to submit the data and then you have to certify the data. So just very broadly laying out the steps. So the CLS module reporting system, so this is within the fee-for-service data collection system. And for the approximately 2,000 labs that reported back in 2017, this may look familiar because it's the exact same as it was. But for any of those new 1,700 labs, they're going to have to register using the new registration process. And it's important to note that there's two different roles here. There's a submitter and a certifier, and I'll get into those in just a moment. And CMS has a website here that'll help walk you through the different steps there. So I definitely refer you to that if this is new to you. So as far as submitting data, so again, there's a submitter and a certifier. So the submitter is the individual from the laboratory who submits the data via the portal. And again, there's a handy URL there that CMS has provided that you can access and get some additional details. So you can upload the data one lab test at a time, or there is a way to bulk upload using a template. And so the template is basically a file that you can download and then fill in. It's really important to note that you cannot modify or add columns to the particular file. And here you can see it's relatively simple. There's only four fields that you need to fill in. So what is the HCPCS code? What is the payment rate that was received, the volume of tests, and then the NPI number. So within one tax identification number or TIN, you can have multiple NPIs, so you can collapse those into a single file for upload. So again, you can upload things singly, one by one, or bulk via the template. The next step is certifying the data. And so this is a different individual than was who submitted the data to begin with. And so the people who can do that are a president or chief financial officer of the laboratory or an individual who has been appointed as a data certifier. And the certifier is going to certify the accuracy and completeness of the applicable information that is submitted. So, and it can't be the same person who submitted the data to begin with. And so the other thing to note is that if there are errors that are found, it can't be corrected by the certifier. It has to go back to the submitter for correction before it can be certified. And then once the certifier has certified the data for that period, the submission closes and no more data can be entered for that tax identification number. So you have to make sure that any errors are corrected before the certification is completed, or at that point, you have to go through the help desk at the address below. All right. So how are these data going to be used? So there's the private payer data is going to be used to calculate the weighted mean of the data for each applicable CLFS code. And then the weighted median is going to be used to determine the calendar year 2027 CLFS payment rate. So this is where a potential reduction in the reimbursement could come in. And so if the private payer rate is less than the current rate by up to 15%, there will be a 15% cut to the payment rate for the coming year. But if it's greater than 15%, they're going to cap it at 15%. And so this is what we observed in the prior round of median calculation, where a larger number of tests than CMS expected had that maximum 15% rate cap applied. And then if there aren't data, they're basically going to say the weighted median is going to be the payment rate for calendar year 2027. All right, for ADLTs, there's going to be no changes to the process. And so just a reminder for folks that a ADLT is a type of clinical laboratory test that's furnished by a single laboratory. It's either FDA authorized or meets one of these criteria. So it's a biomarker analysis of multiple biomarkers of DNA, RNA, or proteins. It uses an algorithm to predict the probability of a specific individual patient, and it provides new information that can't be obtained by any other lab test by itself. So For ADLTs, for the initial period, there's three. So the period after of 3 calendar quarters after the ADLT status is granted, the payment is the actual discharge. And then that payment rate for the ADLT is equal to the weighted median after that initial period. So there's a very limited number of these out there, but it does apply to some laboratories that would have AMP members in them. So there is a penalty for not complying. And CMS does have the authority to issue monetary penalties. And those penalties are up to $10,000 per day, adjusted for inflation, for each failure to report or misrepresentation or omission. So if you think of all the tests that are potentially within scope of reporting, and if each one of those had a problem, it could have $10,000 per day fine assessed. So this could add up very, very quickly. So submitting and making sure that the submissions are accurate is really important. All right, so here's some resources for preparing for the next reporting period. So again, from the CMS CLFS website, we talked about a bunch of different resources that CMS provides. And then there's also the Medicare Learning Network updates. You can see that there. And CMS also has a help desk, and their email address is at the very bottom. So we still think that comprehensive reform to PAMA is needed. So there have been several attempts to reform PAMA over the years. So as Dr. Patel mentioned, this PAMA was a law that was enacted in 2014. So we've been living with PAMA for about a dozen years or so now. And AMP has been very active in this area, and we've signed on with other stakeholders calling for PAMA reform. The most recent iteration of this is the Results Act, or Reforming and Enhancing Sustainable Updates to Laboratory Testing Services. And Results is a great acronym for this. And you can see all the organizations that are also in support of the Results Act and reformation of the current PAMA system. So just a high level overview of what the Results Act would do. So this is legislation that was introduced into both the House and the Senate, so bicameral, back in September of 2025. It's bipartisan. You can see that there are Democrats and Republicans, both in the House and the Senate there, listed as sponsors. And if we look at the key differences, so again, current system is PAMA, Results Act is on the right there. So the data collection period under the current system, so it's going to be based on the rates that their data that was collected from January 1st of 2025 through the end of June 2025. If we look at the Results Act, that would move the collection period forward, and it wouldn't begin until January 1st of next year. If we look at the reporting period, so right now, or actually starting in May, collecting the data from last year, putting it together, and then you have until July of this year to submit that data to CMS, and then that process will repeat every 3 years. If we look under the Results Act, what's being proposed is basically the collection period would move to 2028. So we wouldn't have to report it until January 1st to March of 2028. And then we would have a 4-year period before we'd have to do that process again. So stretching out the data reporting period and the cadence of the reporting. If we look at the payment cuts, so we already mentioned that PAMA can cut up to 15% from the current rate, and we can do it every reporting period. Results Act scales that back to 5%, and those would potentially start in 2029. And if we look at who is actually responsible for reporting, it's going to be all applicable laboratories under PAMA. And under the Results Act, there's actually a couple of different categories. So there's widely available laboratory tests versus non-widely available laboratory tests. And we'll get into that in just a minute. So for widely available tests, these are where there are greater than 100 providers that are submitting data. And what's great about the Results Act is it takes the burden off of the laboratories for those higher volume tests. And it uses a public database to collect the data. So this is a database that collects private payer data for these specific tests. And so again, takes a lot of this reporting burden off of the laboratories themselves and then reflects what the insurance companies are actually paying to laboratories. There's a couple of nuances about the database itself. So you can see there it's a national nonprofit organization. It's not affiliated with the government, insurance, et cetera, and has at least 50 billion claims in their database. So that really narrows down the scope of what databases can be used for this. But there are databases in existence that fulfill those criteria that could be used. So this isn't creating something new. This is actually using resources that are already available. The second category of laboratory tests are non-widely available. And so that is defined as less than 100 providers offering that test. And in those cases, the individual labs are going to have to report the payment data. So there's still some burden on labs for less common tests. And so we think that a lot of molecular laboratories are going to fall under that particular definition. And we're working to adjust that to potentially expand what's considered widely available versus not by working with our legislators. And then if there are no data, which could certainly happen, especially in the molecular pathology space, they're going to use crosswalk or gap filled payment information to crosswalk. So that's how those payment rates are going to be decided. So we need your help to contact your legislators. So here's a QR code. This will take you to an action alert where you can submit comments to your legislators through the AMP platform. So highly recommend that you take that step. And if you can meet with your legislators either in the district or Washington, D.C., that would also be greatly appreciated. And with that, we've had several questions that were received prior to us recording this webinar. So we're going to introduce our panelists and then we will answer the questions. So Vicki and Clarissa, I'd like to ask you to join and introduce yourselves.
Hi, I'm Dr. Vicki Pratt. I'm past president of AMP. I've been living with PAMA for a long time, so I think that's why I'm here today.
And I'm Clarissa Blattner. I'm the Senior Director for Revenue and Payer Optimization at Siphon. I've actually been in the laboratory industry for over 25 years. I'm a certified coder and have been working actually within the lab at 3 different molecular diagnostic labs, as well as my current role at Siphon.
Thank you so much for being here and sharing your experience and expertise with our community.
Thank you. I am Samantha Peterson. I am the policy manager at AMP, and I will be presenting the questions that you all have submitted. So our first question is PAMA reporting a regulatory requirement?
Yes, so this is a federal law. And so all applicable laboratories have to report the required data for that 2025 collection period. And it has to be done from May to July of this year. And as I mentioned, there's some pretty large monetary penalties that laboratories could be subject to if they don't report or report inaccurate data.
Here. Do we need to report if we only have Medicaid and or privately insured patients?
So I'll answer that question. So if you or your lab, you're unsure whether you're an applicable laboratory, we here at AMP encourage you to seek advice directly from CMS to determine if you're an applicable lab. If you do not bill Medicare, then it is likely that you would not meet the majority revenue, or you would be in the low expenditures thresholds and would not be defined as an applicable lab. So again, contact CMS is your best bet for determining whether you're an applicable lab or not.
Are there any molecular specific requirements?
I can take that one. The requirements are the same regardless of the type of testing your lab offers. Really, the only difference is reporting requirements for tests that are considered ADLTs, which Dr. Connick defined earlier in the presentation. And this is really a narrow exemption or exception since only about 18 ADLTs are in existence right now. So outside of that, the requirements apply broadly.
What changes are there in the reporting data process that are different from last time?
Samantha, that's a great question, and I can take that. So while the overall structure of PAMA reporting remains largely consistent with prior cycles, there are several important updates that laboratories should understand for the upcoming reporting period. And both Dr. Patel and Dr. Koenig actually summarize this nicely. So first, more laboratories may now meet the definition of an applicable laboratory. CMS has clarified and maintained regulatory requirements that can allow certain hospital outreach laboratories and physician office laboratories to qualify, depending on how they receive and bill Medicare revenues. As a result, laboratories that did not report in previous cycles should reassess whether they meet the applicable laboratory criteria for this reporting period. Secondly, the private payer data collection period has been updated, as mentioned before. For this cycle, laboratories must report private payer rate data from January 1st through June 30th of 2025. And this is a change from prior reporting cycles that relied on older data periods, and it reflects CMS's effort to use more current market payment information when setting the clinical laboratory fee schedule rates. And third, CMS has clarified operational flexibility related to reporting across multiple NPIs. Laboratories that operate multiple NPIs under a single tax identification number may report applicable data collectively at the tax number level. This can help streamline reporting for larger organizations with multiple billing entities, although it remains important to ensure that all required private payer rate and volume data are accurately captured. And then finally, laboratories should be aware that the reporting window itself is approaching. So applicable laboratories must submit required data to CMS during the reporting period of May 1st, 2026 through July 31st, 2026, because data extraction and validation can take significant time, and CMS encourages laboratories to begin preparing well in advance.
Thank you for your answer, Clarissa. Does the entire claim need to be paid in the final order for all tests to qualify?
So no, CMS actually evaluates final payment at the individual laboratory test code level and not at the overall claim level. So what this means is that when multiple laboratory tests are billed on the same claim, each test must be assessed independently to determine whether final payment occurred during the private payer data collection period. So, for example, if test A and test B are billed on the same claim, and the final payment for test A occurs during the data collection period, the private payer rate and volume data for test A would be considered applicable information and must be reported to CMS. However, if the final payment for, let's just say, test B does not occur until after the data collection period, the private payer data for test B would not be included in reporting for that cycle. So laboratories should therefore ensure that their data extraction processes are capable of identifying final allowed payments and payment dates at the test or HIPPICS code level, rather than relying solely on a claim level payment status. And this is particularly important for claims that may be partially paid, adjusted, appealed, or reprocessed across different timeframes.
Fantastic. Thank you so much for that answer. Uh, Vicky, should a laboratory report applicable information if it only has applicable information for one test?
Absolutely less. Yes, if the laboratory meets the definition of an applicable laboratory, then that single test is subject to the reporting and data collection requirements and must report that information.
Will CMS clean the reported data?
Um, Many stakeholders have asked CMS about that because in the previous reporting, there was what we believe to be significant errors. That we could see wide swings of $36,000 from the least paid test to the highest paid test. Um, so CMS has stated that the law does not give them authority, and the reported data is what it is once it's received at the agency. And then once it's received at the agency will then calculate it, the weighted median. However, CMS has communicated that they will reach out to laboratories if there appears to be any issues and encourage labs to report early so that they can work with labs to address any possible errors.
Yeah. Is there a limit to how much payment for a specific CPT code will increase or decrease in 2027?
I could take that one. Yes, there is a limit, and it's 15%. So the cap is 15%. However, I'll note that under the Results Act, which is proposed, legislation that AMP and other laboratory stakeholders are supporting, that cap would be reduced to 5%.
Thank you. Will all tests experience a reduction in payment after this reporting cycle?
And Samantha, I can take this one. So no, not all laboratory tests will experience a reduction in payment following this reporting cycle. So under PAMA, CMS uses the private payer rate data submitted by applicable laboratories to calculate a weighted median payment rate for each test. Depending on how reported private payer rates compare to current clinical laboratory fee schedule payment amounts, some tests may see decreases, some may remain relatively stable, and others may see increases. At this time, CMS cannot determine the impact on specific tests because payment updates will depend on the data submitted during the reporting period. So once CMS analyzes the reported information, new clinical lab fee schedule payment rates will be established and implemented according to the statutory phase-in limits on annual payment reductions. Looking back on at previous reporting cycles, many molecular pathology tests experienced payment reductions, while a smaller portion saw increases. Stakeholders have noted that a large share of reported data came from independent laboratories, which raised ongoing questions about whether the data fully reflected the broader laboratory market. For this reporting cycle, CMS has indicated that regulatory clarifications and policy updates may result in more laboratories, including hospital outreach laboratories, qualifying as applicable laboratories and reporting data. At the same time, professional organizations such as AMP and other laboratory stakeholders continue to advocate for legislative reforms, including proposals like the Results Act, which aims to address remaining concerns related to data representativeness, reporting burden, and payment stability under PAMA.
Thank you. How will CMS set a payment rate if no data is reported?
I can answer this one. So if CMS receives no applicable information for a given CPT code, CMS will use crosswalking or gap filling to price the test. And then these tests will be discussed at a special public meeting held in the fall of 2026.
Fantastic. And for our final question, what is the likelihood that the Results Act will become law?
Happy to take this one. Um, so we've known that PAMA has had problems since it was passed in 2014, and our legislators have heard about that continuously since that time. And they've responded. And the way they've responded is by delaying the implementation of PAMA. And we've only gone through one reporting period, pretty much in the last 10 years, whereas we should have gone through multiple under the law. And so they've been responsive and recognize that this is a concern and that this is going to impact patient care if PAMA continues to exist in its current form. So with that said, you can never tell exactly what's going to happen with legislation. Sometimes things will move very quickly, and sometimes things that seem very sensible don't get passed. And what I can say is that oftentimes, whether or not an individual piece of legislation actually moves and gets passed comes down to specific interactions that constituents have with their legislators. And you can never predict exactly which relationship is going to be important at which time. And so, for the sake of our laboratories, for the sake of our patients, highly recommend that AMP members use the tools available on AMP's website to contact your legislators and express your concern around PAMA and why the Results Act should get passed. And if you're able to meet with your legislators in person or their staff, again, highly recommend that because we are the experts in molecular pathology. We're the people taking care of patients directly, either within the hospital or laboratory or through our corporations. And getting paid for what we do at a fair rate is really important. So again, highly recommend you use those tools to contact your legislators so that we can get the Results Act passed this year.
Thank you. You can find the action items on the amp.org website under advocacy under Take Action. I would like to take a moment to thank our presenters and panelists for joining us today, and thank you all for your attention on this matter.